Welcome to the Hotflashing podcast. Today I'm interviewing someone I've been wanting to interview for so long. It's Dr. Felice Gersh. She's an integrative OB-GYN, works in California, and she is a practitioner of rhythmic physiologic dosing. And I think this is an area of hormone therapy that doesn't get highlighted enough, nor do people understand how different it is from regular hormone therapy dosing. So I cannot wait to just ask her every question because I've been following her on social media, and sometimes what she says seems wacky until you realize what RPD is, where it comes from, and I have a bunch of questions for her. So if you were interested in this, you're interested in hormone therapy, you're interested in finding out about the entire ecosystem of hormone therapy prescribing, I mean, this is what I'm going into in the Hot Truth About Hormone Therapy, my new guide that you can figure this all out in under 3 hours, 2 if you're fast. And in the show notes, you can find it. But this is one area, and it's just, there's such a range, you guys, like more than 10. So anyway, without further ado, here is Dr. Gersh.
Hit it.
Okay. I am so excited to talk to you because I've been following you on social media and trying to figure out what it is you do and you're talking about. And all roads for rhythmic physiologic dosing sort of lead back to you.
Well, have to say it's still evolving. Okay. Yeah. And that's the good thing, I think, is that I'm not stuck. I don't have like a prepackaged program, and that if I undo it, if I unwind it, then I have to tell all the people that did the program before, sorry, made a mistake, don't do what I said. So I'm just flexible, and I go with the data as best it exists, which is always a challenge. But here's the thing. I always say I'm a very simple thinker. We have to, if we're going to go and do something that is unnatural, which is what medicine is all about, like it or not. That's, when they say, but that's not natural. It's like, is there anything we do that is natural? I mean, we're trying to evade natural consequences. We're trying to make life better. And we're going to try to, replace like irreparably damaged joints or eye lenses or whatever, So I forget the whole natural thing. But when you look at doing something that's unnatural, you want to do it in a way that is aligned with natural. I always say, what's the biggest failed experiment of thinking we're smarter than nature? We'll make food that tastes better than natural food. We'll put in more fat, sugar, and salt. Or we'll make food that doesn't spoil. We'll put in trans fat, right? So how's that worked out for us? Creating ultra-processed food, not too well. So creating hormone regimens that never exist in any, not even close, in any woman at any stage of life is a failed idea. That's not aligned with how our genes work, with how our cells are supposed to be informed of what to do, because that's, after all, what hormones are. They're like the directions to the cells, like this is what you should do. So we have to try to match up to nature as best we can. So here's the thing about menopause, okay? So nature created us in such a way, it's just what it is, that our reproduction and our hormone production are like this. They're completely interconnected, that you can't separate them. They're, completely one thing. Okay. So when you lose reproduction, which you have to, because it took me a while to figure out why we have to go through menopause, but of course we do. If we were having babies, especially thousands of years ago, but even now, and we're in our 40s and 50s, and we're actually conceiving and we get pregnant because we're always forever fertile, then we would die in pregnancy. Our babies would die. How would that serve any purpose for nature? So nature has to end that, so that we live to take care of our existing children and can do, the grandmother thing or whatever, right? We can't do much of anything if we all die in childbirth or when we're pregnant. So we have to lose our reproduction. And with it goes our hormones, because you can't make estradiol or progesterone if you don't have any eggs, right? So they're goodbye. So what we're trying to do is uncouple it. It's like, all right, goodbye fertility, but keep the hormones. So if we're going to keep the hormones, we want to keep them the way they are aligned with the way nature gave them to us, which is complex, because we are complex creatures. So our natural hormones in a menstrual cycle are not low dose static. That's like the main thing to know. They are not. You don't have a little bit of estradiol And sometimes people don't even use estradiol, but we'll just assume they know what they're doing. They're going to use the hormones that the ovaries make, estradiol and progesterone, because, that was not always a thing and still isn't always a thing. But if you're using estradiol, the ovaries don't make a little bit the same every day. And progesterone, the ovaries don't make some every day, just put a little bit out every day. That's not the way the human female body evolved. So all I'm saying with the cyclic regimen, and then I've evolved how I deliver the progesterone, but is to mimic-ish, I always have the ish, a menstrual cycle, which has a rhythm. And there's a purpose to this madness, okay? It's not just about creating babies, because in order to have a successful pregnancy and be successfully reproductively fertile, you need to have optimally functioning organs throughout the body. You need to have a great, neurological system, circulatory system. You need to have a great, musculoskeletal system, skin, kidneys, you name it. Everything has to be working optimally. So these hormones, that's why I call them the hormones of life. They're the givers of life and the maintainers of a healthy life. So the simple thing is, I'm just trying to similar-ish keep the hormones in a level, to keep them at a level consistent with what a young woman would have, because after all, women are the healthiest, like in their early 20s, most fertile is most healthy. And then we want to have physiologic, consistent with nature levels-ish, there's always that ish, and then we want to have similar-ish levels of progesterone somewhat in the rhythm, which is like 2 weeks out of a cycle, not every single day, of the progesterone. And that is going to change how receptors are turned on and off of multiple different hormones, how genes are turned on and off, including things like tumor suppressor genes, and so on. And I'm still using a sort of a dummy down version. That's why I'm looking at how can I make it even more aligned with the normal menstrual cycle without overwhelming my patients with too much complexity, by giving too many different doses through the cycle and so on, so that people can actually live with it and also not have crazy irregular bleeding with it, that you have timed, expected bleeding. So that you have timed expected bleeding. So, in a nutshell, I'm trying to help a woman to stay optimally healthy, similar-ish to how she would be in her fertile years, by giving hormones consistent with the fertile years.
This is crazy. Okay, so a person who walks into a regular OB-GYN's office and would be given regular hormone therapy would get, a 0.50 patch that they would change twice a week, or a 0.075 patch that they would change twice a week, and they would get 100 or 200 progesterone that they would take nightly, and that would be the same every day. And that's what you're saying is that's too low, and that's not what would happen at your healthiest levels. So what would they get if they came to you?
Well, it's not the same for everyone.
Okay.
Because just so you know, it's not what you give, it's what you get into you. And that's really an important takeaway, because when they did I was around when the first patches came on the market. In fact, I was speaking in those days a lot for big pharma, sometimes to the betterment or the worse. I always thought I was doing the right thing, and they always were drugs I thought were really good. But I was around when the first patches came out, and I actually spoke, especially with the dot, when it turned into that newer system of delivery with the patch, what they called the matrix dot, where the patch became much smaller and flat. So I knew all the original studies. And when you gave the same dose patch to, say, 10 different women, you got 10 different levels of estradiol in their blood. So it's highly variable to the individual how a woman absorbs the hormone from any of these instruments, whether it's gel or patches and such. So you got to measure levels, which is not yet, but it's getting there, but not as fast as I'd like, standard routine practice where you measure levels. And why is it that the standard protocols don't care about levels? Because they don't care about healthy longevity. That is not their agenda. They're doing one thing only. They're trying to, reduce night sweats and hot flashes, which are only one small piece of what menopause in terms of even overt symptoms is about. In menopause into menopause, even the words are wrong. The whole thing is like thought of as wrong. Thinking that the whole process is about about periods and the uterus when it's about the ovaries and hormones. So the conventional world hasn't caught up with science, which is really absurd considering, our level of knowledge and how it's not being accessed. So the conventional world is still doing symptom reduction and not even global symptom, just some symptom reduction. So the mantra from the Women's Health Initiative, and have you talked about that very much, the Women's Health Initiative?
I haven't spoken to anyone from the Women's Health Initiative, but we've spoken about it lots.
But I just didn't know if your audience would know, about it, that dreadful study, which did muck up a lot of stuff for a lot of women. I mean, irreparably so. But from that study, the mantra, which was flawed in so many ways, but the mantra that developed from that study was, because hormones were then looked at as evil, damaging, dangerous, all these negatives, was the lowest dose, and then they added in for the shortest period of time. Well, the shortest period of time is sort of like been modified-ish, but not in everybody's mind, so it's all over the place with timing, like how long you use it and such. But in terms of just dosing, the mantra is it's still out there, the smallest dose. So I would say, okay, what do you want the smallest dose of? Well, how about poison? If I said to you, hey, how much arsenic would you like today? You'd probably say, no, thank you. I will pass on it. I'd like none. Okay, because arsenic is a toxic heavy metal. So less is best. When you're talking about poison, less is best. Like, how much air pollution would you like today? How about none? So less is best for something that's harmful, dangerous, bad, right? So what's best? Well, we don't how do we know intuitively what's best? Best is best, right? What's best? So how are you going to know what's best? So we look to, once again, what I said, when are women healthiest? When they're most fertile. So you want to look at those hormones. You don't want to go to lowest. Lowest makes no sense. If I said to you, okay, I'm going to prescribe exercise because I'm a good doctor. So, I understand this. You're supposed to exercise. So let's have you do 5 minutes a week. Okay, like maybe you can walk to your car. Okay, 5 minutes a week. There you go. You'd say, maybe doctor, that isn't the right dose of exercise. Maybe 5 minutes is not the same as 30 minutes, like 5 days a week, and throw in 3 days of resistance training. Dose matters. Why is it that people are thinking with hormones, well, dose doesn't matter? Well, dose doesn't matter if your goal is simply reducing certain symptoms, because then whatever dose it takes, and if you think it's an evil product, less is best, but hormones are wonderful. I embrace them. Why would less be? I'll give you have your thyroid gland was removed because you had this ginormous goiter. That's a gigantic thyroid. And so it was blocking your throat. You couldn't breathe. So they took out your thyroid. It happens rarely. Okay. So no thyroid gland. We'll say, I'm going to give you the lowest amount of thyroid hormone just to keep you sort of alive, okay? I don't care about any of the sequela. This is like nonsense. When you put it into other contexts, like lowest dose of exercise, lowest dose of thyroid hormone. It's like, what the heck? Lowest amount of sleep. It's like, you can keep going on. Lowest intake of vegetables. Lowest is not best. Best is best. Yeah.
How many times higher than regular hormone therapy would your approach be?
Well, it depends, because in some of these online distributor, I call you like hormone mills or distributors, they start with 0.025 patches. Now, if you measure levels, and this has been done, so I'm not reinventing any wheels here, but if you do measurement of levels, you will find that they're deep into menopausal range. You're going to barely budge, if at all. You're not going to see any change. Okay, that would be nonsense, but that's actually prescribed quite a bit. Or even 0.0375, you're going to see barely any change. It's still going to be in the menopausal level. When they did the KEEP study, that was a subsequent study after the Women's Health Initiative, which was to look at a few things, but the primary endpoint was looking at cardiovascular effects. But here's the thing, they used some low-dose Premarin, we won't go into that, but even for the patch, they used the 0.05, okay, 0.05 milligram dose. And they measured levels, which I appreciate that they did that, but the highest that anyone seemed to get was about 40 picograms per mil of estradiol in the blood. That is still in the menopausal range, and that was like the highest they got. So all the women who were in that study on that dose, 0.05 milligrams, they stayed in the menopausal range, which is like under 50, if you know numbers. So just know it's under 50 is still kind of menopausal range. And some of them would be 30, 20. And with many of these hormone delivery systems, like the spray and some of the gels that they put on their arm, they stay in the menopausal level range. But it's interesting because if the goal is just reducing night sweats, hot flashes, it's weird, but even like almost like a whiff of anything, a whiff of testosterone, a whiff of progesterone, a whiff of estradiol seems to suppress over time. It may take 3 months, but and I don't know it's that different from placebo, but in any case, it does seem to reduce those symptoms over time, even the teensiest amount. But that's not going to get you where you want to go if you want healthy longevity, if you want to maintain and optimize every other organ system, starting with brain and going on down. You need to have dose, and that's not going to get you there when you're staying in the menopausal level. So generally speaking, most of my patients will end up on the highest dose patch, which is not a high dose, because when these were created, high was not what they were looking for, or physiologic was. They even call 0.1 high dose. That's not high dose. It's often compatible with a physiologic number in terms of, you might get a level that's in the 70s, 80s. Sometimes you'll get 100. So you have to measure. But some people, they don't absorb it that well, and they have to use more than one patch, or you just give up on the patches and then you go to gels. And then generally speaking, if I'm using the gels, I'll use the highest dose, which isn't a high dose. That's 1.25 milligrams. And sometimes that's inadequate, and then you have to use 2. And so, but you definitely want to measure levels. And I have in some of the articles that I've published, in like one that was a couple of years ago in Mayo Clinic Proceedings, I said the goal is to try to get around 100 picograms per mil, which is still way below the luteal phase in most women. That's like the second half after ovulation. So that's why I'm looking at, because there is some data, published data, and we know how a menstrual cycle doses that, the levels of a menstrual cycle, we know very well, but they are variable for different women. Nothing is exactly the same in all women. But there are some studies, they're very little studies, but they looked at giving a higher amount of estradiol along with the progesterone, and the progesterone would only be given to mimic a menstrual cycle kind of an approach for 2 weeks of every cycle. Because in a real healthy reproductive age woman, the amount of estradiol produced when there is also being produced, goes up. So, and there's reasons for that. Because of the interaction of the receptors between these hormones to maintain like a good status quo of things throughout the body. So that's what I'm looking at, is increasing the dose of the estradiol when the progesterone comes on the scene, so that you don't have too much down regulation of the estradiol receptor alpha, which is involved in creating growth factors. Because we don't want, in a normal menstrual cycle, to keep the uterine lining growing during the second half of the cycle, the luteal, also known as secretory phase. We want to stop the growing of the lining and then make it like blossom. That's what the progesterone does. But we don't want to have the progesterone overwhelm the estradiol and downregulate too much the growth factors, so that you don't have them elsewhere in the body doing their proper thing. So that's where I'm now looking at in the immediate near future, like just for women who are willing to do it. It's not that complex. Say they're using one patch of a 0.1 during the first half without the progesterone, and then the second half they're using the progesterone, and then we use either 1.5 or 2 patches during that second half. And it depends on the levels. So we want to have levels consistent with what human females who are healthy have.
Okay, so that's an evolution in your prescribing.
Right. So I'm just saying, you're just like, things that are coming up. But the way it is for most women now is that they keep the same level of estradiol, even though that is truly not physiologic exactly, but at least you're in a range, a level consistent with what a woman would actually have who's not in menopause, right? Yeah. We don't want to be in a menopausal range for every single day of our life, in menopause. What's the point of giving hormones? We want to get out of that level of menopausal range.
And this is a regime where you will have a menstrual cycle. You will have a bleed. Can you talk about that?
Yeah.
Am I correct in that? And can you describe what happens there and why?
If you have a uterus, that's the way it goes. So here it is, ladies. Okay. So we have to embrace our femininity and what we are and how we were, created. That in order to be optimally healthy, we have to have these rhythms, these beautiful rhythms of hormones, not static, not low dose, beautiful rhythms. And you need to have growth factors. Okay, that's the estradiol. I give lectures on so many different things it does. And one of the things it does is it helps to create, it's essential for creating growth factors. Now, growth factors, for those of you out there who are like peptide thing people, they always say everything. So like, what about peptides? Well, all these are peptides, just so you know. They're chains of amino acids. But here's the thing. In order to have proper growth, restoration, maintenance, creating new cells from your stem cell pool to replace dead cells, all that requires growth factors. And there's loads of different growth factors. So if we just take the brain, for example, we have brain-derived neurotrophic factor, we have nerve growth factor. Now, brain-derived neurotrophic factor is a key to actually creating through a pathway, creating new mitochondria, we call biogenesis. You cannot function without energy. Mitochondria are the little structures in cells that do many things, but one of the biggest things is that they create what's called ATP, which is energy, okay? So without these growth factors, you're not going to have proper energy in your brain. By the way, without that, you're on the road to things like confusion, dementia, depression, anxiety, because all those are interconnected. And so you need to have these things. You need to create neurotransmitters, all of these require growth factors. And if you look at other tissues, we have vascular endothelial growth factor, which helps to restore and create new blood vessels. We need growth factors. Well, in order to have growth factors, you need to have adequate levels of estradiol. You can't have tiny levels. And progesterone down regulates the receptor alpha. Estradiol has 3 basic types of receptors, and they're complex in themselves. There's alpha, beta, and a G protein coupled receptor. And the last one works only on the cell membrane to create rapid effects. And the other 2, alpha and beta, work in the nucleus. We call them nuclear receptors, but also on the cell membrane. So and they interact with one another. So it's a complex system. You need all of them to make things work properly. You can't just give one receptor. That's why I'm not in favor of using these pharmaceuticals that have a limited action on select receptors, because that's not the way the human body works. And in any organ system, you need the balance of these different receptors being activated, downregulated. It's like really complex. And I'm not thinking that we're qualified as humans to micromanage every cell. So we have to macro manage. We give the basic hormones at physiologic ranges of levels, and then let the body micromanage its own cells. And at the cellular level, it's just too complex. But when you give the hormones in this way, then you're going to get the perfect balance of growth factors. When you give progesterone, the rationale for giving progesterone every single day, at night, is to create to not create growth factors, to downregulate the estrogen receptor alpha so you don't grow the uterine lining. so you don't have bleeding. That's the goal. By the way, depending on the dose of estrogen used, about 70 up to 70% of women are going to have breakthrough bleeding anyway. This doesn't even work very well, this system, unless you have very, very tiny doses of estradiol, so little that you're creating almost no growth factors. Then you have the progesterone every day down regulating the receptor to create growth factors so you don't grow the uterine lining. But here's the rub. If you're not going to create growth factors and grow the uterine lining, you're not going to grow the brain, you're not going to restore, you're not going to grow new bone, you're not going to replace with stem cells, new cells. You're going to have no growth factors anywhere. You can't have no growth factors happening in the uterus and then have them working elsewhere. This is a package deal. The body is one whole. So you either grow the uterine lining, and have optimal growth factors to the best of our ability everywhere in the body, in all these organ systems, to grow muscle and bone and repair and rejuvenate and everything else. And that includes growing the uterine lining, because we're a package deal. And if you grow the uterine lining, you can't just indefinitely grow it. It's going to just randomly fall out, which happens to a lot of women. I said like 70% of women will have some spotting or irregular bleeding anyway. So you grow it and you create a predictable bleed for just a few days every month. Or your option always is, well, I only care about reducing some symptoms. I'm not looking for optimization. And I let people have their choice. If you don't want to have a period, I know how to prescribe hormones to lower your chance. Anybody on the planet can learn in about 10 minutes how to prescribe hormones at teensy doses, and give a very tiny amount of estradiol and then give nightly progesterone. Okay? That doesn't take much knowledge. There's not a lot of nuance with that or anything. What's complicated is trying to optimize, because then you do have to deal with growth factors and you do have to deal with this uterus, which is not the organ we want to rejuvenate. But when we give hormones optimally, we are rejuvenating every organ. And that includes the breasts, by the way. That's why some women will get breast tenderness. On a mammogram, their breasts will be denser because the structures of the breast, the lobules that make the milk and the ducts that carry the milk to the nipple, when you don't have any hormones, they literally shrivel. They shrivel up. And all that's really left that you can see on a mammogram is fat and connective tissue. But if you did a mammogram on a 25-year-old, you see nothing. It's just the breasts are so dense because you have all these healthy lobules and ducts that are there. Well, when you rejuvenate the breasts with physiologic hormone levels, you're going to rejuvenate the ducts. That's not a bad thing. That's not risking increased cancer. In fact, the data is actually supporting, now that they're looking at it, that it's reducing not eliminating, we don't have that ability, lowering the risk though of breast cancer. But you're going to rejuvenate the breast so they'll be denser on a mammogram because the ducts and the lobules are like coming back to life. Your uterine lining will come back to life. But it's how you frame it in your head. If you say, if my uterine lining is coming back to life from growth factors, if my breasts are coming back to life from growth factors, how about my brain? How about my bones, my muscles, my skin? All these different organ systems, they're also coming back. They're also being rejuvenated. So it's all how you frame it in your head. And, what I'm really thinking, I really am, that we should set up clinics. Anyone interested, contact me. We should set up clinics where we can do for women who are done having their children. They're not going to have any more. They're not even thinking of it. Maybe they're 45. So even if they wanted to, it's kind of difficult once you're over 45, right? So, and if they want, they can have an optional endometrial ablation. Are you familiar with that? They're using different energy sources. Usually it's radio frequency or heat to destroy the uterine lining. You're not destroying the uterus. You're not destroying anything else. You're just destroying the endometrium. That's what sheds. That's what grows. That's what bleeds. So if you destroy the uterine lining, then you will not, or you'll have tiny bleed. Sometimes it's just a tiny, tiny bit of bleeding or none at all, forever. You can give, like if you're still cycling, you stop having you have the hormones, but you won't bleed anymore. Then women could be on cyclic hormone therapy with a uterus and they won't bleed. Why, women can walk into any plastic surgeon's office whenever they feel like and say, I want breast implants. I want a butt implant. I want a facelift or whatever, right? And nobody blinks an eye. It's like some of these surgeries have significant risk. Some of these facelifts take 6 hours, So women can have cosmetic surgery on demand. Nobody questions it. No. So why can't women have endometrial ablation on demand? Why can't they just walk in and say, please destroy my uterine lining so I don't have to deal with periods when I go into menopause and go on rhythmic hormones? I'm not having a hysterectomy. That's a big surgery compared. I mean, this is a 10-minute procedure and you're done.
Have you done that? Have you done that with anyone yet?
Well, here's the thing. I did many, many endometrial ablations. I've done many, many, but just actually, it was just right before the whole COVID thing. So, like 2020, early 2020, I decided to retire myself from doing surgeries. I did thousands of surgeries, the most complicated GYN surgeries. I taught surgery at USC Keck School of Medicine, but I decided to retire myself from surgery. So I've done many, but I'm not doing them now, but I know all about them. I've done plenty of them. I know how easy they are to do, but they're done by gynecologists. They're not done by other types of doctors, but they're so simple. I never had a single complication from a single one of them. You do them right. It's certainly less dangerous than doing all these facelifts and things, So if women should want it, why can't they have it? But if you don't have it, like I don't have an endometrial ablation, it wasn't something on my to-do list. I didn't have any problems. So you just live with having a few days of bleeding every month. It isn't that terrible. But it's a personal choice. You want optimal health, optimal healthy longevity, then you need optimal hormones. And we women are complex. And if you want to dummy it down to a tiny bit of hormones every day, static, low dose, you can do it. But just know that there's no long-term data to support it. And then, I've also moved away from giving oral progesterone, just like I moved away a long time ago from giving oral estradiol for the same reason. It's so ridiculous. When you take either one of them orally, they go to the liver, which does tremendous modifications. And what gets into your bloodstream is not the same as what you swallowed. And that's another big deal. So, we need to think about everything. Nothing should be off, or...
Yeah. I've heard you speak about this, and it's confusing, I think, for people. You're talking about vaginal or even rectal progesterone. So when you talk about that, people still getting the benefits of the progesterone, and is that progesterone going into the bloodstream, even though it's delivered vaginally and rectally?
Much more so, yeah. So when you deliver the progesterone orally, let's just start with that. It goes to the liver, where there are a lot of enzymes in the liver. The liver is a master organ of metabolic transformation. They call it biotransformation. It changes one molecule into another. That's part of how it modifies molecules in the body for removal from the body through this whole process. Glucuronidation, sulfation, methylation, there's all these different pathways to change hormones and other molecules in the body into other forms so they become water soluble. You can, excrete them with the stool or put them into the urine and get them out of the body. And it's a metabolic powerhouse. In terms of progesterone, close to 90%, 80-90%, close to 90% of all the swallowed progesterone is converted into other stuff called metabolites by the liver. And the main of these, like 30 different things, is a molecule that's a metabolite of progesterone called allopregnanolone. Now, allopregnanolone is a different molecule than progesterone, but it comes from progesterone. And it's a wonderful molecule, okay? In the right amount, in the right place, at the right time. So it's another one of those things. Dose matters. So a little normal amount, appropriate amount of allopregnanolone is being researched as a prevention and treatment for Alzheimer's. It binds to the GABA A receptor. GABA is the neurotransmitter in the brain that creates calmness, and it's an inhibiting, like they call it, inhibitory neurotransmitter. So it allows your brain to kind of drift off. You can fall asleep. It's calming. They give allopregnanolone, a synthetic version, as a big dose pharmaceutical, and it's a big dose for just a couple of weeks as a treatment for postpartum depression. It is actually, allopregnanolone is a pharmaceutical. And as a pharmaceutical, it has a category called, it's a category 4 type of pharmaceutical. In other words, it's a controlled substance. It's in the same category as Valium, Xanax. It's a controlled substance. It has all the same warnings. You can't just prescribe it. You have to use a special thing. You have to use the special forms and things because it is viewed as equivalent to giving someone Valium or Xanax. Now, it doesn't work in exactly the same spot on the GABA receptors, but very similar, close by, and it works in the same manner. So both the pharmaceuticals and allopregnanolone as a pharmaceutical or as a natural product work in the same way, basically, to increase GABA. Well, GABA is wonderful, but once again, too much of a good thing is a bad thing. Too much GABA will prevent proper memory formation. Remember, it's inhibitory to the brain. It's like, how many good memories are you making as you're falling asleep? So the brain is in a different state. So there is rat data. Once again, I'm back to rat data. I have to deal with what is. In rats, if you give them allopregnanolone at a super dose, more than they would ever naturally have, which is what you get when you get the oral progesterone. You get an abnormally high amount of allopregnanolone made from the progesterone, converted from the progesterone in the liver that circulates in the blood, 2.5 to 5 times the maximum amount anybody would ever naturally have. But in rats, when you do the equivalent, they get rat dementia. We don't have long-term data like that in humans because nobody's done any data collection. It's really hard to do studies about dementia in humans because how long are you going to wait, if you start, and how long do you give it for? And that's sort of the problem, because somebody may start and then 10, 15, 20 years later they get dementia. Who's making the nexus? Who's connecting the two, right? But the thing is that in humans, we do have some data that if you are given too much allopregnanolone, that you can have difficulty making memories. And there's also quite a bit of published data that if you have allopregnanolone too much every single day, it alters your appetite and it causes weight gain, just what every woman wants in menopause. So we may be actually inducing some cognitive issues that are negative by giving this progesterone orally every single night and basically having so much of it turn into allopregnanolone, and we may be causing weight gain, two not desirable things. Plus, the amount of progesterone that you get into the blood, although it is variable for different women, just like giving the patch is variable how much you get into the blood, typically get very small amounts of progesterone. And we love progesterone. Progesterone is not just about the uterine lining. Progesterone has receptors in many places all over the body. Progesterone in its own right is neuroprotective. It maintains and produces myelin, the insulation of nerves, which is so critical. It also increases the activity of the osteoblasts. Those are the cells in bone that make bone, okay? It's neuroprotective, it's great for the bones, and it's anti-inflammatory. It reduces inflammation. It's great for the skin. I mean, it's just does so many different things all over the body. So we don't get enough progesterone and we get too much allopregnanolone. Remember, dose matters. You're getting the wrong amount of these two important molecules. So giving oral progesterone really doesn't make sense. Now, the problem is that we don't have any good commercial transdermal product for progesterone. It can be given from a compounding pharmacy as a cream, and I know, and other people have used it, we know it does get absorbed. But what we don't have is data. We don't have studies showing how to dose it, and so we don't have the protection of the uterine lining kind of data, but I use it as a last resort and I've never had a single problem. But it is important that patients who use topical progesterone know that we don't have any clear clinical published data on its data, in regarding its dosing and safety and long-term use and that sort of thing. But we have a ton of data on vaginal and even rectal progesterone. Most of that data is coming from the infertility world. The infertility doctors never use oral progesterone. They would never touch it. because it doesn't make sense. They don't get the dose of progesterone they need. When they give it vaginally, it does have what we call the first pass through the uterus. So it really concentrates in the uterine lining and creates what we call complete secretory conversion. So it really gets that uterine lining perfect for implantation of an embryo or the perfect period, and it just comes right out, so you don't have the dribs and drabs and the long bleeding and the cramps and stuff because the uterus is trying to get out the lining and it's having difficulty. When you have complete secretory conversion, it just like peels out and it's easy.
Can I ask a question that might seem dumb? But when you tell me that vaginal estrogen stays local, but if I put progesterone in my vagina, it is absorbed into the bloodstream, that makes me, you didn't tell me that vaginal estrogen stays local.
No,
that's what they tell us.
Well, that's ridiculous.
But that's what everyone says. It's local.
Well, that's wrong. Okay, not. It's okay. No, I'm glad you brought that up. Yeah. Okay, it's the dose. Yeah. It is absorbed. It is 100% going to be absorbed. Anything you put in there is going to be absorbed. Okay.
You could put vodka in your vagina and you would probably get drunk.
Yeah, I haven't done that study.
No.
I probably could. Okay, so that's why we worry about when people put in, toxic chemicals in their tampons, and then spermicides. I mean, this stuff does get absorbed. So what's the dose? Remember, I just keep the dose matters. What's the dose of the commercial vaginal estradiol product? 0.1 milligrams. 0.1, and that's per milliliter or per gram. They're the same. So what are they dosing? Typically, the dose that's recommended is 0.1 milligrams 2 times a week. I just want people to know that is a very tiny dose, okay? So yes, it does get absorbed, and they have shown that it can have a little bit of effect on blood levels, but it stays so deep into the menopausal range that it's considered insignificant, but it does get absorbed. So I'm glad you brought that up. Yes, if you wanted to give all your estrogen for systemic purposes into the vagina, you could do that and you'll get good blood levels. But we don't do that because you get that first pass through the uterus. You're going to really ultra grow your uterine lining if you put, systemic doses of estradiol into the vagina.
Do you have a perspective on women who have progesterone intolerance? I hear about that every time I talk about progesterone.
Well, not all, but most of those women are intolerant to high doses of allopregnanolone. They're usually taking, because how many women do you know that are using it the way I'm now advocating, vaginally? And by the way, rectally, there's a lot of data. It absorbs incredibly well rectally. And if you lube up the whole thing, you know what I call it? Mouth opposite. It's just a tube. That's just mouth opposite. Get over it. Okay. So it slips right in. And the nice thing about the rectal application is that you get incredibly good blood levels, gets very well absorbed, and there's no drainage. Anything you put in the vagina, some of it's going to come out. You can't, it doesn't all like evaporate or something. So you're going to have some kind of discharge. You don't have any of that when you put it into the rectum because we have a sphincter there that keeps everything in. Unless you have fecal incontinence, you don't have to worry. Nothing's draining out of there.
Yes. So
progesterone intolerance is usually allopregnanolone intolerance because they're taking it orally. And then they're getting all this bolus of allopregnanolone, which is sedating to the brain. So many women, but not all, but many, will feel like they're drugged. Well, guess what? I told you, it's just like taking Valium or Xanax. It really is. So it's not a normal sleep. It does change your sleep because it's not going to be, it's like not being induced like from natural sleep cycles and falling asleep. It's like taking Valium every night. It really is. And some women feel dopey in the morning. They really feel like they have a hangover. They feel like the room is spinning. And a lot of it is that. But there's also this small group of women that have what's called a paradoxical effect. They seem to have the opposite effect. Instead of it being like calming and sedating, it's sort of activating and it creates agitation. So those women, occasionally, we have to just forego the progesterone and every few months give a synthetic progestin just to clean out the uterine lining. It's a small percentage, but it does exist that some people, now that's for the oral. Very few people are intolerant to the vaginal or rectal. If you didn't have problems during your own menstrual cycles, you won't have problems with this.
So that gets the oral, vaginal and rectal gets around that issue.
Yeah, because they don't turn into that high amount of allopregnanolone.
I'm told by other people I interview that blood levels aren't the whole story, that we have a lot of hormones that are made in our various tissues. And there's a whole ecosystem of prescribing, you know, we go from like you all the way around to the people who are like, don't eat a chickpea because it's estrogenic, you know, and in the middle you have progesterone forward people. And so they talk a lot about you have estrogen in your tissues, you have estrogen in your muscles and so I wanted to ask you about that because the testing of blood levels, I just wondered how you weigh that and from your perspective, what's the levels in the tissues as well?
Well, we know, for example, during the reproductive years in the brain creates many steroids. They call them neurosteroids because they're in the neurological tissue, and the brain has the enzyme systems to make them, both from precursor hormones like testosterone. Testosterone is the precursor to all estradiol. 100% of estradiol comes from testosterone. Okay, well, men have a lot of testosterone. They should. And in their brains during the reproductive years, men make 6 to 8 times as much estradiol in their brains compared to women. Women are not designed to make huge amounts of estradiol in their brains because they don't have huge amounts of testosterone. And even if they did, that's not how they evolved. They don't have the systems in place. They can make some for sure, but they don't have the same systems in place like men do because they're just different. Men are just different in a lot of different ways. So men make a lot of estradiol in their brains. Women make some, but it doesn't matter during the reproductive years because women have all that estradiol coming from their ovaries that get it into the brain. So after menopause, we have ongoing, and before menopause, paracrine production of hormones. Paracrine means they're made locally in the tissues for those tissues. They're not circulating, okay? And there's also intracrine production of hormones. That means in the cell itself. So none of this can be measured. But here's the thing. That's never going to pick up the slack in women. Never, ever will it pick up the slack, making it locally in tissues. That's not how we evolved. So it's not like, we'll just make more in our brain. It doesn't work that way. We'll just make more in our skin because the men make a lot of estradiol in their skin. The enzyme aromatase that converts testosterone into estradiol is in the skin. That's one reason why women who are older, look at their skin. It's become so thin, translucent. And if they get a skin injury, they get a laceration, it can take so long to heal. There are wound clinics all over the place because of poor healing, slow healing, because growth factors create healing. Okay, you need growth factors to create new tissue, new blood vessels to heal, and activates the immune system to gobble up the damaged dead cells and so on. So when that's not active enough, it doesn't work. You don't heal well. The skin has the enzymes to make estradiol. It's not going to make enough. Just look at the skin of an 80-year-old woman. You can see her skin is clearly not making enough estradiol. Look at the skin of a 19-year-old woman. So it doesn't make up the slack. That's why we don't die, folks, because we do make some hormones. We're not zero, but we are too low. So you can say we're not zero, but we're very insufficient. And making it in the tissues is not going to make up the difference. And you can give testosterone till the cows come home. It doesn't mean it's going to turn into estradiol in any particular tissue because we're not evolved to do that. Okay? That's why if someone wants to transgender from female to male and they give them a ton of testosterone, they don't become like gigantic boob ladies and they don't become like super females. All that testosterone is not turned into estradiol. It stays as testosterone. So that's nonsense. I'm just telling you to think that you're just going to make it up by making it locally in the tissues. You make enough to survive. You don't make enough to thrive.
Okay. And you are so out of the mainstream approach to hormone therapy. And you're telling me that you were in there and you've just moved and adapted and evolved.
But it hasn't. The reality is that when you look at much data, evolve in terms of the original studies, even the KEEP study, the ELITE study, these were done since the Women's Health Initiative. They all use cyclic hormones. I did not invent cyclic hormones. I'm just reinventing it. It's been used. It's like it was the standard of care. I want people to know this has been the standard of care. In the ELITE study, ELITE, They used vaginal progesterone gel. This is just since the Women's Health Initiative. I did not invent these things. I'm just saying that the invention is not what I'm doing. The invention is low dose static. That's what's new on the scene, not what I'm saying. I'm just perpetuating what was done that is being lost to this craziness of low dose static, which is the ultimate dumbing down of the female physiology and what women need to thrive.
And how is this connected to the Wiley protocol? The Wiley protocol is still around, and it became, I think we know about it from the American actress Suzanne Summers, and she talked about the Wiley protocol. It was a woman named Wiley who created it. How is RPD? Is it connected? Is it got its birth in it? Like, how does that work?
Well, yes and no, because cyclic hormones were what was used. I mean, back in the 19s, cyclic hormones were used. I mean, that's like, I just want people who don't have the historical background. And see, it's history for a lot of doctors. For me, it's my memory. Okay. So I was there. This is what we did. Cyclic hormones were what we did. What Susie Wiley did, I think, is brilliant, just not ready for prime time. Okay. She said, let's really mimic, like to the nth degree. Let's try to mimic a menstrual cycle. Let's try to give hormones so that they fluctuate and you get the spikes and like to be like identical. The reality is that it's more complex than most women are willing to do, like to try to change the dose like every single day practically, to have these different fluctuations. And as well, the dosing has never been well studied. So the dosing is all over the place because most women have a lot of transitional problems, so much bleeding. But that's not to say there aren't some women who are on that program that thrive and do wonderfully. But it could take 2 years before you figure out how to dose it for any particular woman. They're going to have all kinds of bleeding and ultrasounds, maybe biopsies, and people don't want to put up with that. But I think the idea is brilliant. And I think that I'm moving slightly in that direction when I said earlier that maybe what we should at least do is have a different dose of estradiol when the progesterone comes on the scene, because that's aligned more with the way nature made us, so that we have sort of a compensation for some of the effects of the progesterone on the estrogen receptor. But to do it the way that Wiley did, which is brilliant, is just not feasible at this time. And I have been begging, literally like on my hands and knees, begging to get some clinical studies, but there are none. There are none. And I don't do anything that has no clinical data. I try never to do things that, I can't say, well, at least we have this kind of study or this kind of data. The only real data we have for that is human female menstrual cycle, which of course we really understand. And it would be ideal if we could have like insulin pumps, only they're estrogen progesterone pumps, so that we could have it automated. And maybe this will happen where you can have this little pump instilled in you and it pumps out physiologic levels of hormones to mimic the exact way that a menstrual cycle worked with the hormones, and we will do the best. That would be great. But it would be even greater, and people are working on this, really and truly. New ovaries. I'll tell you, that's the future. We get a new set of ovaries, and we can just implant it in our hip. We're not going to be fertile, but we have the hormones of a 21-year-old when we're 60. I mean, what the heck? I want that. What we're doing is so, we'll say very premature in terms of its like optimization. Okay. It's like, a new set of ovaries would be fantastic. Wiley's protocol, with the cyclic hormones, actually to mimic a menstrual cycle, is brilliant. It's just not ready for prime time. We have no published data. We don't really know exactly how to dose it. Most women would never talk about compliance. You're going to get the lowest compliance. People are going to drop out. So you have to have both science backed and you have to have usability backed, right? It has to be that people can do it, and not bleed all over the place and have all these problems. So I think it's a brilliant idea. I'm hoping someday And I don't hope I live to see it, where we can have either like implantables, where we have little pumps of these hormones because even the hormones we're giving, hormones are not produced by the ovaries where you just have a bolus come out in the morning or something, That's where the patch is supposed to be like more consistent, but it's not really, because the amount delivered goes down each day. But in a real human, healthy young female, she has pulses of hormones coming out, different amounts at different times of the day, not just over the cycle of the cycle, and so on. So we're very primitive. That's the word I was looking for. What we're doing now is still very primitive, but it's better. At least I hope what we're doing is better than giving nothing. But now, like I said, for the static low dose, I'm not 100% sure over the long haul if it is better than nothing. I don't know. And I'm just going to go with what seems most sensible, that we have actual data on how it's absorbed, how it works, and aligned with human physiology. I don't want to go back to that old failed experiment of we can make food that lasts forever and tastes better than real food. We're not going to create a hormone regimen that works better than what nature gave us. So we want to sort of mimic. That's what I want to make sure everyone understands. Go with what's natural. Natural food, natural hormones, natural rhythms.
Yeah, so your argument is this is safer. If people say, how is that safe? You're like, this is safer. We already did it. That's your basic argument.
Yeah, and this is what we've been doing for the last 40 years. After the Women's Health Initiative, it's like the wisdom of the past was lost. And they did some research and they found that something like 80% of healthcare professionals today were not in practice in 2002 when the Women's Health Initiative came out. They have no historical context of what women were getting before 2002. They have no idea. They weren't around and they were never taught. I lived through all that. So I know that we were doing cyclic hormones before the Women's Health Initiative. I'm not inventing, I'm reinventing.
You're like a disruptor, but you were originally here, so you're like the anti-disruptor. I hope I get the chance to talk to you again as this evolves. And thank you so much. I really appreciate it.
My pleasure.
Hotflash Inc. was created and is hosted by Anne-Marie McQueen, produced and edited by Sonia Mack. The information contained in this podcast is intended for informational purposes only and is not intended for the purpose of diagnosing, treating, curing, or preventing any disease. Before using any products referenced on the podcast, consult with your healthcare provider, read all labels, and heed all directions and cautions that accompany the products. Information received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem, i.e. menopause or anything else, or any healthcare questions, please promptly see your healthcare provider. This podcast, including Anne-Marie McQueen and any producers or editors, disclaim any responsibility from any possible adverse effects from the use of any information contained herein. Opinions of guests on this podcast are their own, and the podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about a guest's qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have direct or indirect financial interest in products or services referred to herein. This podcast is owned by Hotflash Inc. Media.